Hello, greetings from Dr. Sunita from India. Today, I'm going to speak on the fertility after severe Asherman. How can we improve the result? I would like to thank my entire team, GCH, for giving me this opportunity. I congratulate them, and I also thank FIGO for this wonderful conference. I don't have anything to disclose. Asherman syndrome is a debatable topic, and in a gynecological field, there is no clear consensus about the management and treatment. It is characterized by variable scarring inside the cavity, and it is also the cause of menstrual disturbance, fertility, or the placental abnormalities. Although the first case of this was published way back in 1894, it is only after 54 years that a full description of it was carried out by Israel gynecologist Joseph Asherman. The advent of hysteroscopy has revolutionized its diagnosis and management and is therefore considered the most valuable tool. The American Society has considered with the scoring of mild, moderate, severe, depending upon the cavity involved, the type, and the menstrual pattern. The most common causes of Asherman is infection, especially in a country like India, tuberculous endometritis. And the another common cause is repeated curettage causing damage to the basal endometrium. Let's talk about tuberculosis or endometritis. Tuberculosis is responsible in 16% of cases of infertility, and infertility is seen around 40 to 40% of these genital cocks. And that's why in Asia and India, tuberculosis is still labeled as an important factor and it's to be evaluated for tubes and for the cavity in cases of infertility. High index of suspicion is mandatory, especially in early stages where you get to see such miliary tuberculosis with hydrosulfings, but this may be associated with severe Asherman or may not be. Doesn't mean acute or chronic stages decide the stage of intrauterine cavity. This is how the chronic stage look like. For the interest of, because this is FIGO, I thought of showing you few videos of laparoscopy, how plastered the abdomen will be, and even your entry also can sometimes damage this bowel. Now, today, we have to see about this infective pathology as one of the cause, apart from repeated curettage. I'm not going to talk about fertilization, though both the gets affected. Let's talk about the implantation. And what should be the treatment strategy in Asherman syndrome? If I can summarize, is only four main steps. One, do the hysteroscopic adhesiolysis. Second, think about adhesion prevention because here the basal endometrium is involved and very high chances that re-adhesion can happen. These are the various ways you can think about or restore the normal endometrium either by hormonal treatment and stem cells, which we will be talking about in this. And fourth important thing is after this, how you will assess whether excellent 3D sonography or second look hysteroscopy. Let's talk about this. Endoscope is our stethoscope, and it has given us an opportunity to be innovative and creative. Today, I'll be talking about hysteroscopy. When I talk about hysteroscopy, friends, I always want to talk about office hysteroscope. Can you see that flimsy adhesion, which is a primary stage of the tuberculous endometritis? If you dilate, you can miss out this tuberculous endometritis because not necessarily you will get a histopathological picture. But in Asherman, let me talk about this chronic stage. This is the early stage, but if it progresses, remain without attention, this is where we land up where we can't even locate the internal os. So how do we go about it? Is just the cervical folds. All folds lead to the direction of an internal os. And the best instrument to use is the scissor, the blunt scissor, and just have a nix on this. These are the thick fibrous band of adhesions, and you need to have a patience to just rotate the scissor and cut. The cutting should be fiber by fiber, just little bit fast forwarding it. Now, I'm not sure what will be the inside picture, but if I have done myself 3D sonography, I saw some part of the cavity. I'm little more confident, and I'm knowing that I'm going in a right direction. And this is where the cavity leads in, and you can do the further adhesiolysis and prepare the cavity for this. Sometimes the cavity is more than half obliterated, and what is important is if you are lucky to see the cornu, it acts as an indicator and keeps on doing a small fiber by fiber cuts. Keep good intrauterine pressure so that you are always in the center of the cavity, not too anteriorly or not too posteriorly, which can cause damage. Sometimes you can enter in and the cavity is obliterated on all the sides, and maybe with the fluid pressure you are able to open up these flimsy fibers. These are more flimsy adhesion than these fibrous adhesions, but anyhow you can't see even the cornal opening. What is needed is small cuts. Keep on pulling your camera to the isthmus so that you can have a panoramic view of the cavity, and then you decide how you should be going. Always remember, you may not have to do everything in one go. You may do this in two sittings, giving first partial adhesiolysis, then hormonal treatment, and then again the second look hysteroscopy and completing the job, because you don't wish to perforate such cavities, because then you spoil all the purpose of fertility for this patient. Your aim is to convert this tubular looking cavity into the triangular. This may be the eye-shaped cavity into the triangular cavity. What is most important is sometimes you may have just the internal os here, and with your skill you can open up. So look at this internal os, and I can create the cavity. The problem is not redesigning the cavity. Any good hysteroscopic surgeon will be able to do. What is important is you can see hardly there is a basal layer or an endometrial layer, and everything is fibrous. So how do you maintain it? Maintaining the cavity is the most important and challenging the thing. And today, for next 3 to 4 minutes, I would like to focus on autologous bone marrow derived stem cells in Asherman treated patient. We all know that stem cells has capacity to regenerate any organ where you instill in. So can I mobilize the endometrial stem cells from the bone marrow and regenerate the endometrial cavity? There are various publications which have come in this decade. We all know Carlos Simon having worked, and we also did our publication on the same, where Asherman treated or atrophic endometrium, you can create and design it. We at Pune, at Solo Stem Cells, are doing this. What we do is only autologous bone marrow. You can just take out the bone marrow, and then you can separate it into the lab, into the stem cells. So patient is pre-medicated. You have a hyperbaric oxygen chamber. It's fantastic. But if you don't have it, it's okay. You can still work out on giving a pre-oxygenation and antioxidants to it, and you can aspirate it from the bone marrow. Here, the posterior iliac bone is the most preferred bone, even in our center, because you can nicely take out from the posterior iliac bone about 150 to 200 cc of those stem cells. This bone marrow then goes into the lab, this bag, and it gets attached to the automated machine, and it is complete computerized digital technology by which the entire bone marrow gets separated into 3 different bags, and one of the bag is the stem cell, the other 2 bags are the blood components and other factor. What is important is these stem cells then you can inject subendometrial, either hysteroscopic control or in the intrauterine. There are various ways. The time doesn't allow me to discuss. I'm going to show you one nice video clip. Here, the cavity was bad. We did first incision, and then we put on our hormones, and we wanted to see how the cavity is. Yes, again, it got adherent. Now, these are the cavities which are little hopeful. Though they are bad, such are the cases. If you select it for the endometrial regeneration, it will be fantabulous. So what is important is first create the cavity. So fiber by fiber, keep on cutting the fibers. You know that the other corner is an indicator and go. I'm not able to see the cavity on this side. I would like to go and see how I can manage to work on that cavity. What I have to do is give little better and more progressive cut, and you will see that once I cut, I will be able to see into the cavity and the cornal opening. Fantabulous. This is a pink color opening, and I can cut out these fibers. Now, what is important to see is once you created this cavity, pink cavity, and this is completely the white cavity. Now, this cavity, one can think about regenerating because it is not getting maintained. So these are the cases where subendometrial infusion of autologous bone marrow derived stem cells along with the estrogen therapy can be given. And the second look hysteroscopy is performed after the 4 weeks. That is what we follow in our center. And look at this beautiful cavity got regenerated. So the complete plastered cavity you will be able to create with your hysteroscopy and with autologous bone marrow derived stem cells into the working functional cavity where hopes of implantation can be there. Otherwise, third party reproduction is the only option remains. Now here again, I can do a little bit adhesiolysis and make the cavity more looking normal. So endoscopy and stem cells has given us an opportunity to help our patient in best possible way. There are ethical concerns in India, and the ICMR has its own restriction, and still the autologous bone marrow derived stem cells in infertility is still considered as a research. We at Solo Stem Cell got a permission to do the clinical trials, and we also have to say just 30 seconds more. I will talk about PRP, the platelet rich plasma for such refractory endometrium, the paper which we published in 2017, where we got not only improvement into the thickness, but also the vascularity has become, the sparse vascularity has become more into the moderate vascularity. So one can think about even after the stem cell doing periodic platelet rich plasma instillation and work on the cavity. Friends, after climbing a great hill, one finds that there are many more hills to climb. ART, endoscopy, stem cells, high risk obstetrics. You need to keep on doing everything to give a live birth rate to your patients. Thank you so much for patience hearing, and thank you for giving me an opportunity to be with you all. Thank you.